Hey, good day and welcome back to Cardiac Rhythms number 6, a continuation in our critical care course, Rise Up for Critical Care. And to begin with, of course, we always want to remind ourselves when we're talking about cardiac rhythms, we're looking at whether it's fast or slow. Does every P to P interval equal an R to R interval? Does every P have a QRS? Is the PR constant? And what's the width of the QRS? That helps us to define normal QRS tachycardia versus wide, normal QRS bradycardia versus wide. And we covered a lot of these dysrhythms in our talks together. Okay, salient points thus far. Rapid heart rate, persistent tachycardia is always a warning sign. We always have a responsibility to pay attention to it and investigate. Pain, agitation, high fever, and is this heart rate compensatory for tissue acidosis? So one of the things to think about is as we're titrating up on vasopressors, as the heart rate goes up, be sure that you have not actually burdened the heart significantly, and you know that, whether or not the patient has acidosis that's getting better or worse. Rapid heart rate can limit individual filling of each relaxation phase of the ventricle, and therefore the amount of volume that's ejected by the heart per beat. Okay, persistent tachycardia is always a concern, a cause for concern, and bradycardia with hypotension is always abnormal. Very important to remember, two major groups of cells, the defined pacemaker cells, sinus node, AV junction, Purkinje fiber, they should always be in charge of the heart, but sometimes other pesky myocardial cells will reach threshold first, and when they reach threshold first, they're in charge of the heart. Atrial cells are potassium and calcium dependent for depolarization. Ventricular cells are potassium and sodium dependent for depolarization. I must be brain infarcting, but in the keywords, atrial tachydysrhythmias respond to beta block, potassium, and calcium for depolarization, and ventricular tachydysrhythmias respond to potassium and sodium channel antagonists or blockers for control of ventricular dysrhythmias. And so, with our salient points, the heart block, first degree and second degree Mobitz type 1s, usually secondary to diseases within the AV junction, tend to be ischemic, tend to be more stable. Second degree Mobitz type 2 and third degree block, usually at the His bundle or below, very unstable dysrhythms and usually require a consideration for pacemaker. First degree AV block is associated with increased risk for AFib and also an increased all-cause mortality. Second degree heart block, if you see two non-conducted P waves falling right on time but no conduction to the QRS, time to consider a pacemaker. Reversible causes of complete heart block include medications, both beta blockers and other potassium and sodium and calcium channel antagonists, and also associated with Lyme disease. Okay. Heart blocks are prodromal for asystole, and that happens when they occur below the common bundle of His. So we diagnose heart blocks, remember, by looking at P to P regularity, by looking at QRS irregular or at a much lower rate than the P to P, and also by checking for the regular PR interval. Right bundle branch block points upright in V1, left bundle branch block points upright in V6. Right bundle branch block is often rate related and limited. Left bundle branch block is not usually rate related, and it's prodrome for failure. So those are our salient points thus far. Remind ourselves that V1 and V2 have the best view of the right ventricle, and V5 and V6 have the best view of the left ventricle. Look for the RR pattern in those pairs of leads, and just remember, if you have that abnormal morphology, but the width is less than 0.12 or 120 milliseconds, then that is probably an incomplete bundle branch block. In RBB, look for the M in the right-sided leads and a W in the left. In left bundle branch block, look for an W in the right-sided leads and an M in the left. What that signifies is dyssynchronous depolarization of the ventricles, so now you see both ventricles depolarize instead of them as a single entity. Okay, last but not least, salient point. Remember, the sum of atrial and ventricular electrical components, the atrial waveform is the P wave, the ventricular waveform is the QRS to the T wave, which is repolarization, and normally sinus node paces the heart and the P wave precedes the QRS activity. So it's PQRST. Sometimes the atria and the ventricles are paced separately, such as in complete heart block. So what we see is the P to P interval is constant, but the R to R interval is inconstant. The EKG gives us a beautiful recording of electrical activity, but doesn't tell us anything about the mechanics. The electrical activity is what makes calcium available for contraction, but mechanics we're going to measure with a pulsatile wave, with a pleth, with an A line, with our fingers on the pulse. EKG is not a direct depiction of abnormalities, and it does not record all of the heart activities. So, just remember, we always look to rhythms and instability. Instability are things such as hypotension, hypoperfusion, chest pain, dysrhythmia, coronary ischemia, shortness of breath, pulmonary edema. And remember, hypotension should always be accompanied with tachycardia. If it's not, you've got a bigger problem than the hypotension. And hyperthermia should always be accompanied with tachycardia. But remember, targeted temperature management, keeping patients cool, can actually induce bradycardia, as well as the administration of many drugs, but in particular the one you might not think about would be Precedex or dexamethasone. Okay, so to begin, as we move forward, we're going to remind ourselves now we're talking about fast heart rate, tachycardias. And tachycardias present as narrow, complex tachycardias or as wide, complex tachycardias. So narrow, complex tachycardias tend to be supraventricular, meaning from above the junction, depolarized through the normal Purkinje fiber network, so the QRS looks normal, but the rate is irregular, and you often will see profound abnormalities in the atrial visualization. The wide, complex tachycardias, we really only have two: supraventricular, depolarized with the right bundle branch block pattern, and ventricular dysrhythmia. So, first and foremost, we're going to think about sinus tachycardia. Sinus tachycardia means the sinus node is in charge, the P wave is normal, the PR interval is normal, but the sinus node is firing at a more rapid rate than normal. Now, normally, remember, it's 60 to 100. So anything above 100 actually can indicate a sinus tachycardia if the P wave is the same as what you've always seen. It's a normal pathway of conduction and depolarization and a nice regular rate. Now, we see it for lots of reasons, most particularly because the patient's in pain or they're agitated, they have a fever, they have some hypoxia, they may have coronary disease, and we want to treat the cause if we can. And what we might also do is limit the sinus tachycardia by giving beta block therapy, blocking that sympathetic discharge to the sinus node and reducing the firing rate of the sinus node. So this is a beautiful visualization of sinus tachycardia. Every P to P is constant. P to P equals R to R, it's constant. PR segment is constant. Now there is some very unusual things happening on this EKG, but we're not going to worry about them just now. What we're going to remind ourselves is that this rate is very fast. It's somewhere around 180, and I'm only approximating it, looking at it, somewhere close to 180, maybe 170, maybe even 150. But it's a rapid rate, and it's coming from the sinus node. We look again at this visual and we say again, this is a very rapid rate. It's pretty rapid. It's about 150 also. And you can see that there's the P to P interval is constant, the R to R interval is constant, the PR segment is constant, the PR interval is constant, and the QRS is normal width. So this is also a sinus tachycardia. Now we look at some rhythm strips, right, on the 12-lead EKG. So the bottom strips, V1, V2, and V3, are all rhythm strips with tachycardia. P to P interval is constant, R to R interval is constant, the width of the QRS is normal, and you're firing at a rapid rate. Now sometimes we move from our atrial tachycardia or sinus tachycardia to atrial tachycardia, and we talk about rhythms that come from above the ventricle, and in particular we talk about AV nodal rhythms. AV nodal rhythms, also known as reentry tachycardic rhythms, give us the supraventricular tachycardia definition. That means that you're firing at a very, very rapid rate within the AV junction, and actually you are in an abnormal circuit. So it usually means that you have a pathway that's not physiologic, an external pathway to the AV junction. So an abnormal pathway that you were probably born with. One of them is known as Wolff-Parkinson-White. Another one is called Lown-Ganog-Levine. Those pathways conduct rapid impulses without the normal delay through the junction. So one of the things that's very important for us to appreciate here is atrial tachycardia, AV nodal tachycardia, AV nodal reentry tachycardia. They are all from above the ventricle. They are all very rapid and uncontrolled, and they do not actually delay the impulse. Now here's the problem with supraventricular tachydysrhythmias. We have to be very careful, because our number one design is to say, look how tachycardic he is, and it's a normal with QRS, and we'd like to give you some beta block therapy to block the sympathetic discharge. But the problem is that these patients have anomalous pathways or accessory pathways that conduct from atria to ventricle without the delay through the AV junction. So what actually happens is they're going to conduct their impulse through that circuit and then rebound or retrograde conduct through the AV junction. Giving them a beta blocker can make them significantly worse. And that's why with supraventricular tachycardias, the rule of thumb is unless you know it's a sinus tachycardia, you're not going to give a beta blocker. You're going to give, most likely, amiodarone. Potassium channel antagonist might consider something else like Pronestal, which also works with these accessory pathways, but you got to have a cardiology consult to do so. Okay, so when we look at those AV nodal reentry tachycardias, they begin and end in repeated periods. So people are very aware frequently that their heart is beating quite fast. They get very weak. They have fatigue, dizzy, palpitations. And we just want to remind ourselves that this is just a circuit entry beat. So it's just circling around the AV junction. And that atrial depolarization or impulse that polarizes the ventricle is normally conducted through the fast pathway. But when we have a premature atrial depolarization, that fast pathway is still refractory, so the secondary pathway takes over in that accessory beat, and that's what gives us what we call AV nodal reentry tachycardia. This is a visualization, nice normal rhythm, have a PAC, and now I'm in this rapid rate. Remember, we'll look at that and we'll say, well, we're not sure. It might be junctional. I can't really see a P wave, but I don't want to give beta block. That's really the only thing I'm saying to you here. We typically don't want to give a beta blocker. If we give a beta blocker, the rhythm may actually get worse. So if you've given a beta blocker to somebody who you thought had a very profound atrial tachycardia or sinus tachycardia and the rate got worse, it may be related to AV nodal reentry. That's all I'm going to say about that. Because it's not that common, I really want you to know about atrial fib. Ha ha, you said, I already know all about atrial fib, and that's probably true. It is really important to remember that this is the most common dysrhythmia. It's the most common dysrhythmia in the ICU. It's the most common dysrhythmia in the general population. It's a very disorganized, rapid firing from multiple foci in the atria. And that multiple foci is firing at a rate of somewhere between 300 to 500 times a minute. Now, you do not want your ventricles depolarizing that rapidly. So thank goodness the AV junction doesn't conduct that quickly, because otherwise you'd have a heart rate of 500 and you would die. The ventricular pulse actually varies because of your beautiful functional AV junction, which limits the conduction between the atria and the ventricle. So it's very irregular. Just like the atrial impulse is irregular, the ventricular response is irregular, and it can be fast or it can be slow depending on the patient's condition. So the EKG shows normal but irregular complexes. So R interval does not equal the P to P interval. In fact, you haven't got P's, you've got fib waves, right? Typically, we talk about that as being fine oscillations. That's the fibrillation of the F waves. No actual P waves, and your atria is going and your ventricle every once in a while is depolarizing, but you're not optimally filling the ventricle because the atria is fibrillating against a closed valve. So you get a lot of volume in your pulmonary veins, a lot of volume in your systemic veins, and very little volume in the ventricular filling. So what this means to us is, despite the fact that you might think about atrial fib as being an okay dysrhythmia, happens all the time, in a critical patient, it can be life-threatening. A new onset atrial fib in a patient who is unstable and on vasopressors, from my point of view, that's as emergent as VTAC. I need to convert it, and I need to convert it now. My patient's unstable, he's on vasopressors, I'm titrating upwards. Now he has AFib, which tells me that he's got an atrial stretch, stimulation of atrial abnormalities, and he's going to die from his AFib if I don't get him under control. So lots of things cause AFib: coronary artery disease, valvular disease, hypertension, hyperthyroidism, big cause, hyperthyroidism, and some others. And then sometimes we just see patients have atrial fib and we don't know why. We've done all our investigations and we can't figure it out. So on EKG, what we want to remind ourselves of these irritable foci out in the atria firing at a rate of 3 to 600, that the atria is quivering rather than contracting, which means you've limited ventricular filling, and you can't find any P waves. So every once in a while an impulse gets through the ventricle, but it's very, very, very irregular. If lots of impulses are conducted, we will have a rapid ventricular response, and if just a few impulses are conducted, we will have a slow ventricular response. Okay. So our goal is to make sure that the junction doesn't conduct rapidly, right? That's why we use AV junctional blockers, things that are calcium channel antagonists, potassium channel antagonists. We actually want to slow down the conduction of the impulse of the atria into the ventricle. Would we like to stop the atrial fib? You bet we would. But a lot of times we can't do that. Lots of times it's refractory. So very important to say, what can I do right now to help my patient? Okay. So on EKG, we look at atrial fib. We see that the atrial rate is 350, 300 to 600. The ventricular rate could be slow, it could be rapid, but it's irregular. Everything is irregular. There are no P waves, you're fibrillating. There is no PR interval, and the QRS width typically is less than 0.12. Now, remember that if you are rapidly firing from the atria to the ventricle and the junction is conducting it, you may actually have a wide QRS response. So it's going to be very important for us to actually understand that the QRS may be wide because of a rate-related right bundle branch block. That's normally how you see rate-related bundle branch blocks. Okay, so let's take a quick look at this EKG, and you can see in the V1 lead, which is the only lead where it's really apparent, you have fib waves. And across the whole EKG, what you're seeing is this undulating baseline with irregularity of ventricular response. So you might not have recognized it right when you first looked at it. If you didn't have that rhythm strip for V1 that showed you the fib waves, you might have just said, oh, this looks like a little bradycardia. Maybe it's a little bit of heart block. And then on further investigation, you actually see the undulation of the atria. That's the atrial fibrillation. So I want to remind you about acute versus chronic control. When atrial fib is due to an acute event, so that acute event might be an overstretching of the atria, it might be an aggressive pulmonary embolism, it may be afterload that's been put upon the patient with a type of ventilatory support. What we're going to say is with an acute event, of course, we always want to treat the cause. We may also want to visualize if there's the presence of any thrombus. It's always really important to recognize that the single most important reason that you do not cardiovert for AFib is if there is a possibility of thrombus formation, because when we cardiovert, we can actually cause a breaking in the thrombus, which then can move up into the aorta and into the carotid arteries. So acutely, when we want to manage AFib, we would like to give you cardioversion, okay? So we like to give cardioversion to give a synchronous, not an R on T, but a synchronous firing that actually will limit, basically stop the fib waves and allow time for the sinus node to take over. Cardioversion is the most reliable. In 90% of patients, cardioversion works. But pharmacologic therapy sometimes is our choice because we're uncertain about whether or not the patient has a thrombus. And typically our number one therapeutic intervention will be oral or IV administration of amiodarone. Okay, now remember, if your patient is profoundly hypotensive, has significant angina or profound cardiogenic shock, you're going to go ahead and do an emergency synchronized cardioversion. But if hemodynamics are stable and you want to get your patient's heart rate down, you'll give beta block, calcium channel antagonist, or potassium channel antagonist. Sometimes we'll consider elective cardioversion. That's a perfect therapeutic intervention. However, patients must be on anticoagulation for at least 4 weeks and then have a visualization of the presence or absence of thrombus prior to receiving elective cardioversion. Okay, so very different kinds of things that we think about. First and foremost, I just want you to remember, AFib can be a life-threatening dysrhythmia. In an acute patient who's vasopressor dependent, new onset AFib can be life-threatening. Treat it that way. Be aware. When your patient goes into AFib, notify someone immediately. They don't call back, notify them again. Stay on the phone until you get somebody to pay attention to acute onset atrial fibrillation. Okay, long-term. Remember, patients in AFib actually can have hypercoagulation in their pooled blood that actually resides in the atria. So that atrial thrombus, ventricular thrombus, is a major issue, and so these patients are profoundly at risk for stroke. They're also profoundly at risk for the ultimate evolution of heart failure, and we want to anticoagulate them. We use Coumadin, we can use direct thrombin inhibitors, we can use 10A inhibitors. We have such choices today that we don't always have to give Coumadin, and particularly if we're talking about patients who are homeless or can't get to a place where they can have monitoring of their clotting times, which is always required if you're on Coumadin. Our second significant issue with these patients, so anticoagulate and then control their rate. And we're going to use rhythm control if they have symptoms, even if we think we've achieved adequate rate control. We want to always control any kind of paroxysmal atrial fib. So again, if we control ventricular rate, but we really feel the need to control the atrial rate, we may consider some other approaches for those patients. Some of the agents that we can use, like flecainide or propafenone, those require a cardiologist, and they are related to significant pro-arrhythmic effects. So we're very careful about considering those. We also think about ablation. We think about ablation because we want to ablate the area of stimulus in the atria. It's more common to do ablation if you only have one stimulated area, that's what you see with A-flutter, than what you see with atrial fibrillation. It's less likely to do ablation of the atrial sites. And then we think about ablating the AV junction. Now, if we ablate the AV junction, you no longer have conduction from atria to ventricle. You're going to have a ventricular pacemaker, which in and of itself is a problem. And then, of course, Mays surgery, which is an actual surgical procedure removing sites. Okay, we move from AFib to A-flutter. A-flutter, heart rate 200 to 350 times a minute. Typically, that's your atrial rate, not your ventricular rate. But you have very regular electric signals coming from the atria at a very fast but even rate, only one focus firing. And that focus is rapidly conducted down into the ventricle. So when your signal coming from the atria is more rapid than what your ventricle can respond to, which typically it is because it's 200 to 300, and if you're at the higher edge at 300, 325, or 50, your ventricles will not respond that rapidly. So you can actually see that iconic sawtooth pattern on your EKG. That sawtooth pattern actually can tell you that you have an atria that is fluttering. And that flutter, all that means is you have only one abnormal focus in the atria that is discharging, and you have a variable response into the ventricles. Sometimes 2 flutter beats to 1 ventricular response, sometimes 3 or 4, and sometimes at the lower end, more at the 200 level, you can have a 1-to-1 conduction. So that's quite important to us in terms of evaluating our patients and recognizing what their dysrhythm is. If we look at atrial flutter, we just remind ourselves that the waveform of atrial flutter resembles the teeth of a straw, and that the AV junction cannot conduct faster than about 180 beats per minute. And that's why we often look at the ratio of atrial depolarization to ventricular depolarization, flutter waves to ventricular response, and we remind ourselves that this is a dysrhythm of urgency. It's a dysrhythm of urgency. Typically, we see in hypoxia, pulmonary embolism with myocardial infarction. Sometimes we see with chronic lung disease or pneumonia, and we see with obstructive shock. So again, obstruction in communication from right heart to left heart because of a pulmonary embolus, because of a very aggressive ventilatory strategy limiting the blood flow communication between those two ventricles and causing an alteration in atrial stretch and therefore atrial stability. Signs and symptoms: weakness, dizziness, fatigue, chest discomfort, and again, beautiful. Treatments are basically all the same, right? Calcium channel blocker, beta blocker, amiodarone, cardioversion, and anticoagulation. All the same for these atrial dysrhythmias. Always with caution, being sure that patients do not have thrombus formation. Okay, so on EKG, you can see the atrial rate, 220 to 430 here. Ventricular response is typically less than 300, usually less than 200. The rhythm is variable or can be very regular, but the P wave, if there is no P wave, there's a flutter wave and it's sawtooth in appearance. There is no PR interval, and hopefully you have a narrow QRS. But remember, you can have a wide QRS if you are conducting in a right bundle branch block pattern. Okay, so this is a beautiful EKG trace, 2 different EKG traces, and you can see the presence of those flutter waves. So we count the waves looking at the 3-to-1 or 2-to-1 variable conduction of the flutter waves to the ventricles, and remind ourselves that one of our goals is to slow down the conduction into the AV junction and into the ventricles. If we look at this EKG on lead 2, not a problem at all for us to diagnose this as a flutter, because we're looking at the seriousness of those flutter waves. But I do want to remark to you that if I was looking at a lead 1, I was looking at a V2 or a V3, I might not be able to diagnose atrial flutter because I don't see the typical sawtooth pattern in those leads. So 12-lead EKG with the rhythm strip is absolutely essential. The 12-lead EKG itself does not help you diagnose a dysrhythmia, but the long rhythm strip is what helps you to diagnose dysrhythmia. And what you see here is a nice long rhythm strip of lead 2. Okay, so symptoms of tachycardia, there's a lot of them, right? Patient is short of breath, they might feel dizzy, they may be syncopal, they feel the flutter in their chest. All of those require that they're talking to you. They could have chest discomfort, they could have sudden, profound weakness, but most importantly, symptoms of tachycardia could be hypotension and decreased stroke volume. So one of the important things that we talk about is with critically ill patients who have an A-line, we can always attach a device that allows us to look at their stroke volume. That's known as a flow track transducer and an EV1000. We use them a lot in critical care. It helps us to monitor your stroke volume. So if you're having an abnormality of rhythm, I want to see what your stroke volume is. If you've got an A-line, I'm going to attach that transducer, and I'm going to attach that transducer to the EV1000 monitor. That allows me to actually evaluate your stroke volume, which is the most important thing, right? The rhythm leads to mechanical dysfunction. Mechanical dysfunction actually alters the blood flow dynamics so that your tissues are not being perfused appropriately. Now we look at ventricular rhythms as we move forward. Ventricular rhythms, remember, anything that arises from the ventricle is the least efficient because as it rises from the ventricle, it's limiting the atrial delivery of volume into the ventricles. It's the least efficient pacemaker, generates impulses at 20 to 40 beats per minute, and we're going to assume that we have an escape ventricular rhythm if the sinus node fails and if the AV junction fails. So ventricular sites are very prone to irritability. They're very prone to ischemia and electrolyte abnormalities. One of the things I want to remember is if I have an idioventricular rhythm, meaning escape from higher pacemaker, sinus node has failed, AV junction has failed, Purkinje fiber is the only thing depolarizing the heart and keeping me alive. With ventricular rhythms, the T wave is always in the opposite direction. That's completely abnormal. Usually T wave goes in the same direction as your QRS. So very important. And idioventricular rhythms, which are escape from death, Purkinje fibers escaping a higher pacemaker, but not doing it at a rapid rate, doing it at a slow rate. Sometimes it will fire a little bit more rapidly if that's the only control of the heart. You've lost your sinus node, you've lost your AV junction, you have idioventricular rhythm at a more rapid rate. Typically that could be between 50 and 100. Remember that the QRS will be wide and the T wave will be in the opposite direction. Sometimes we see accelerated idioventricular rhythm after we have successfully reperfused an ischemic area. So that might mean, for us, it means that you went to the cath lab, you had a stent, you had an angioplasty, we've opened up a vessel, we've reperfused an area that was previously ischemic. Very often we'll see dysrhythmia, and one of the dysrhythmias that we can see is accelerated idioventricular rhythms. Doesn't affect your prognosis in MI, and we do not treat those patients unless they are unstable, in which case we will try to develop and stimulate the higher pacemaker. We'll never suppress the idioventricular rhythm because that's what's keeping you alive. So when you look at this picture, you can see that if I looked at V1, I might say, oh, it looks like a right bundle branch block pattern. That's exactly what it looks like, because it is a right bundle branch block pattern, but it's not a right bundle branch block. And that is actually because what we're appreciating is that the impulse is arising in the left ventricles, depolarizing the right heart secondarily, so it looks like a right bundle branch block. But when we look more closely, we can see that we don't actually have P waves that are conducting into the ventricles. And you can see this might be a time when people will say, oh, my patient has alternating bundles, because you see in the rhythm strip, looking down in the rhythm strip of V1, lead 2, and V6, you have an upright in V1, then a downwards, and then an upright. Everybody can see that in groups of 3, basically. And I see the same thing when I'm looking at lead 2 and V6. Lots of times people will look at this and say he has an alternating bundle, but actually he has accelerated idioventricular rhythm. Okay, so to something you know a lot about, premature ventricular depolarizations. Sometimes you call them premature ventricular contractions. It's okay with me, whatever you wish to call it, but it's actually about the electrical event, not just the mechanical. But sometimes what we see when we are looking at patients who've been reperfused, who have myocardial ischemia, who have profound hypoxia, who have myocardial stress because they're in tachycardia and they don't have enough good blood flow to maintain the myocardium, we can often see a premature ventricular depolarization. So very important when we look at an EKG, and I'm looking at this one and I see one premature and another premature, and they look exactly the same, so I'm going to call that unifocal, meaning the appearance is the same, so I believe it's coming from the same site. Okay, so very important with the premature ventricular depolarization. The premature ventricular depolarization actually in a retrograde fashion depolarizes the sinus node. So it does something called reset the cadence. That means if I look at R wave 1 to R wave 2 to R wave 3, the amount of time from 1 to 3 will be exactly the amount of time that encompasses the PVC. So if you look at the first beat, that would be R wave 1. The second one is the PVC, but the third one would be what I would call R wave 3. This is what we call a compensatory pause. There's actually no compensation required. You just depolarize the sinus node. So a unique visual with the PVC is compensatory pause, meaning the time before the PVC to the time after the PVC equals 3 of the normal R to R intervals. 3 of the normal R to R intervals. That's called the compensatory pause. Okay. Now, every other beat, if you have normal beat, then ventricular, normal, then ventricular. That's called Bygeminy. We're always concerned about Bygeminy because it's telling us about the increasing ischemia or the increasing irritability of that area in the myocardium that is reaching threshold first and depolarizing the heart. Remember, he who reaches threshold first is in charge of the heart. Sometimes we see it 2 in a row or 3 in a row. We call those couplets or triplets. 2 PVCs in a row, couplet, 3 in a row, triplets. 3 in a row is not too far away from being VTAC. So we're always concerned about that presentation when we're evaluating our patients. Another term that's used for couplets would be salvos, and that would only be good if you wanted to throw your weight around and be very intellectual to say, my patient is having salvos. Normally we just say couplets, 2 in a row. Okay, so very important to appreciate that. Oftentimes cardiology and we ourselves would like to know if there's more than one focus. So what we do is we attach a 12-lead EKG and just run rhythm strips. in all 12 of the leads, just run rhythm strips so that we can look at whether or not PVCs are multifocal. Multifocal PVCs are harder for us to control. They are hallmarks of a very irritable myocardium, and they are prodrome for VTAC or VFib. And so that's a really important concept. If I'm seeing that on the bedside monitor, I'm asking for a 12-lead EKG, and I'm asking for a rhythm strip 12-lead EKG. I'm not trying to diagnose STEMI. I'm trying to look at my patient's rhythm and actually ascertain whether or not there's more than one abnormal focus in the ventricle. Now, you can see here increasing instability of our patients. So you see they have PVCs, they have PVCs, they have multifocal PVCs, and then they have couplets in the first strip, and then in the second strip they have a 8-beat run, and I counted really quickly, so forgive me if my math is wrong, an 8-beat run of VTAC. Okay? So this is a very important concept because increasing unstable areas, multifocality, salvos, triplets, those are telling us about a prodrome for VTAC. We should treat our patients sooner rather than allow them to get into VTAC. Now, one of the things I do want to remind you is when patients come back from the cath lab and they've had an angioplasty or a stent, we actually will frequently see ventricular dysrhythms as reperfusion occurs. And as long as we've notified cardiology, we're okay. Typically, they're not going to really want to treat the patient. They may put the patient on an amiodarone, they may not. They may just say that's a reperfusion dysrhythmia. VTAC is a common reperfusion dysrhythmia when we have unstable myocardium and has lots of abnormal metabolites, not the least of which would be metabolic acid and free ionized calcium, which are hyperirritable to the reperfused areas. So very important for us to appreciate that when we look at our patients. Okay, so VTAC. VTAC, that's a dysrhythmia of 3 or more consecutive abnormal ventricular depolarizations that originate from somewhere in the ventricle, and the rate is greater than 100. It might just be 110 or 120. VTAC accounts for about 80% of wide QRS tachycardia. The other 20% is aberrantly conducted SVT. Now, when we look at VT, we look at how long it's sustained, okay? If you have a less than 30-second run of VT, that is called non-sustained. And that's commonly what you see in reperfusion dysrhythmia after fibrinolytic or after stent or angioplasty, etc. Sustained VT is greater than 30 seconds in duration and typically requires you to terminate it. It's not naturally terminating. You're going to have to terminate it because it creates profound, and it can, not always, but profound significant hemodynamic compromise. That's why you take a pulse. That's why you look at pressure. That's why you look at whether or not the patient has a decreasing pulse ox. All those reasons that tell us whether or not your VTAC is creating hemodynamic instability, because hemodynamically unstable VTAC ventricular tachycardia is going to cause death if you have this hemodynamic compromise. Don't have enough time for the ventricles to fill. Atria is not associated with the ventricle. It's really quite problematic, as you can well imagine. Okay, so typically what we say is VTAC typically is regular, with a rate of 100 to 250. Typically, you do not see VTAC with a rate greater than 250. The duration of the QRS is always wide. Sometimes it's in a right bundle branch block pattern, or it could be in a left bundle branch block pattern. So now the quiz. To have a right bundle branch block pattern, does the impulse arise in the left ventricle, meaning that we then depolarize the right heart second, or does it arise in the right ventricle, meaning that we depolarize the left heart second? Okay. Excellent. If your impulse arises in the left ventricle, you will have a right bundle branch block pattern. If your impulse arises in the right ventricle, you will have a left bundle branch block pattern. Typically, these patients have a very severe abnormal access. It's called no man's land or Northwest Territory. And very, very important that if we have a left bundle branch block pattern with a right axis deviation, that means it's upright in lead 1 and downwards in AVF. We didn't talk about that yet, so don't worry, you didn't miss anything. That's going to give us some very good information about VTAC. Okay, so in VTAC, the QRS morphology. In the chest leads, we typically see with VTAC concordance. Concordance means all leads in the precordial leads, V1 through V6, all point in the same direction, either all upright or all downwards. That's a really important perspective when we're looking at a 12-lead EKG. There's no RS pattern, and actually there's a little bit of a delay to the peak of the R wave. That's called the R wave nadir. With a right bundle branch block pattern, you're going to have an RS or R prime in V1 and a very wide R wave, greater usually than 40 milliseconds, and an RS complex in lead V6. With a left bundle branch block pattern, we have an R in V1 that is longer than 30 milliseconds, still have concordance, everything's going upwards, and that's really important. So you can see what those criteria are, but now let's just take a look at our QRS concordance. So very important to understand that concordance means all your precordial leads point to the same direction. So that's what it says, is predominant deflection of your ventricular depolarization. All upright or all downwards in V1 through V6, okay? Has a specificity of 90%, but not all patients actually present with concordance. So let's just take a quick look at that VTAC in concordance. Okay. So we don't have our quick look here, and I'm not certain what happened to the quick look, but I will share it with you in a later slide deck, if that's okay. So for treatment with VTAC, in hemodynamically compromised patients, we're going to do asynchronous defibrillation if the patient is hemodynamically unstable. If he's hemodynamically stable, we use IV therapy, usually class 1 drugs. Those would be sodium channel antagonists, which we will not do as first choice. We will do amiodarone. VTAC in patients with structural heart disease is almost always now treated with implantation of an implantable cardioverter defibrillator to help manage anticipated VTAC occurrence. Okay, so now to torsade du point. Okay, with torsade du point, there's going to be some really particular things that we think about. So we're going to think about the QT interval from the beginning of the Q wave to the end of the T wave, which I've highlighted here with that little red horseshoe. Reminding ourselves that from the beginning of the Q wave to the end of the T wave is typically less than 0.48, and here it's about 0.44. That's the total ventricular activity, depolarization to repolarization. Many of our agents, many of our medications, not even necessarily antiarrhythmics, but other agents actually prolong the QT syndrome, the QT interval. And with prolongation of the QT, it becomes possible for an electrical event to fire on the unstable time of the ventricles. That's the downside of the T wave. So that causes what we know as R on T phenomena. R on T phenomena can cause quite a few problems. So when we talk about TDP, torsade du point is, in French, the twisting of the points, pointing up, pointing down, pointing up, pointing down. Twisting of the points much like a streamer at a birthday party. So the mechanism is that there's a firing on the downside of your T wave, what we call the relative refractory period, meaning I'm not going to depolarize unless you hit me with a strong impulse. And that strong impulse hitting on the downside of the T wave, this is the electrical activity of the individual cell, but the downside of the T wave can cause me to go into that particular form of VTAC VFib known as torsade du point. So this is a beautiful slide. It's a very old slide that shows my patient's QRS with an after depolarization, and now the patient goes into the twisting of the points known as TDP. So for us at the bedside, one of the most important things is to actually correct our patient's rate, our patient's QT interval for the heart rate. Because the QT interval changes depending on how fast or slow the heart is beating. If your heart is beating fast, the QT interval is shorter, and if it's beating slow, the QT interval is longer, and that's normal physiologically. So what we do is always a rate-corrected QT interval. Now, I don't do my own rate correction. I can, but it requires math, and it requires that you have a calculator that actually can do square roots, and I'm not going to be doing that. So I can go online and look for a corrected QT interval chart, which tells me if you're a man and your heart rate is 100, this is what your corrected QT is. That's really important. Our monitors actually display a QTC. So at a bedside monitor of a critically ill patient, anybody who is receiving any type of IV medication, you need to display QTC on your bedside monitor. Ask your preceptor to show you how to do it. All you have to do is turn it on and then it will display QTC. So if we look at this patient whose heart rate is 66, his QT is 350, but when it's corrected for his heart rate, it's 370. Now the standard is still the same. For men, less than 480. For women, less than 440. Generally, we just say less than 440. QT should be less than 440. But if you take a look at this next patient with a heart rate of 83, his QT is 350 and his QTC is 410. So he's getting mighty close to what we would consider abnormal. When we're hypothermic, when we've gotten Precedex and we have bradycardia, we have really long QTs. When we correct them for the patient's heart rate, they typically look a little bit better than they did before. Okay, so the way we can correct, I get online and call up a QT correction chart. But you can correct it yourself. This is how you do so. QTC equals QT divided by the square root of the R to R interval in seconds, not milliseconds. And that gives us a QT corrected. QT corrected means corrected for your heart rate, that's all. Still have the same normal and abnormal values. It just means we accommodate for the fact that when your heart is beating faster, the actual measured QT may be shorter, but you may actually have a long QT, but it's masked because your heart rate is fast. Okay, so we measure that QT and remind ourselves that that QT is going to give us great information. What we're also going to look at is that our patients frequently will have alternating T waves. Now we're going to see that alternating T waves, and alternating T waves mean that your T waves are not going in the normal direction. That's what we call T wave alternans. Sometimes your T wave will alter every other beat. So you can see first beat in V6, I think, the T wave is down, then the next T wave is up, then the next one is down, and the next one is up, and the next one's down, the next one's up. Those are all hallmarked by the red arrows. Now when you look at lead 2, you can see that all the T waves are down. So it's very important to recognize that typically you have to use the chest lead to evaluate this, and you need a 12-lead EKG. And you can see in most of the other leads you do not have alternating T waves. Okay, so now we just take a quick look at this patient. Basically is the same patient but without the red arrows. And we just talk about what causes a long QT. So when your potassium is low, your mag is low, your calcium is low, and if you're hypothyroid, you'll have a long QT syndrome. Antidysrhythmics in class 1. That's why we don't use class 1 agents anymore without our physicians actually having a cardiology consult. Those would be agents like the three different subgroups of class 1, lidocaine, pronestal, and quinidine. Okay? Then other agents, antipsychotics like Haldol, macrolide or quinolone antibiotics prolong your QT. In fact, QT can be prolonged with lots of medications, so we always need to turn on QTC when we're monitoring critical patients. Ischemia can prolongate your QT, but the other thing that can happen is that you can have a congenital long QT syndrome, and a lot of patients have it. We had a 16-year-old girl who came into our ED who had a cardiac arrest in her math class. Math gives me a cardiac arrest too, ha-ha. But she had a cardiac arrest in her math class. Thank goodness her teacher knew how to do CPR. EMS got there, they shocked her, and immediately following the shock, she had restoration of normal rhythm and return of spontaneous circulation. She came to us neurologically disintact. We actually applied targeted temperature management to her, and at the end of 3 days, she woke up neurologically intact. This year, she graduated from the University of Alabama. That was when she was 16, so that was 6 years ago. And how wonderful was that? Now, she went from us because she was really pediatric. She went to CHOA, where she was actually evaluated in the electrophysiology lab, and she had an ICD implanted. She had 3 brothers and sisters. 2 of them actually also had congenital long QT syndrome that they would not have known about had it not been for their sister. So they all 3, only one of the siblings, did not receive an implantable cardioverter defibrillator. Congenital long QT syndrome is not uncommon, and we want to always be aware that we should be monitoring the QT on our patients. So So I want to show you just typical ST and T wave shape in hypokalemia, and just reminding yourself that in hypokalemia you can have a delay in depolarization and repolarization, and sometimes we see with those patients what we call an after depolarization wave. That's the U wave. It just means that your repolarization has not completed, so you have a second wave of repolarization. Very common to see, but it also puts our patients at risk for a prolongation in QT syndrome and torsade du point. Also in hypocalcemia. So you can see here that what's prolonged here is the ST segment. That's different than the congenital long QT syndrome, because that's not really, it's really the T wave that in the long QT syndrome, that's the problem. T wave's not wide, and there's no T wave abnormality, but in hypocalcemia, the ST segment is prolonged, and that puts you at risk for depolarization on your T wave. Now, it might be a normal depolarization from your sinus node through your AV junction that then fires on your T wave and causes you to go into TDP. Hyperkalemia also puts patients at risk, and that's really significant as well. We always remember that in hyperkalemia, the first sign and symptom of hyperkalemia can be a very, very pointy, large T wave, almost as big as our R wave. Usually a T wave is less than 1/3 of the R, so that gives us a really good visual to be aware of when we're evaluating patients at the bedside. So we just want to remind ourselves about that twisting of the points, right? That it is a form of VTAC where the QRS changes its shape, amplitude, width, and directional point. And the most common causes here, of course, apart from long QT syndrome, are hypomagnesemia and hypokalemia, and response to class 1 agents. Remember, quinidine, prenestol, and lidocaine, generally which you're not using. Okay, now those patients go directly into shock. They have chest pain, they're short of breath, they have very profound hypotension. So number one, keep on top of your patient's electrolytes. Make sure you're replacing them when things are abnormal. A lot of times we're not checking magnesium, and that's really critical for critically ill patients. So we're going to look at potassium, magnesium, and calcium. We're going to do that quite regularly in unstable patients and in patients who have renal dysfunction or patients on CRRT. Now we're going to stop whatever drug has caused a prolongation of your QT syndrome. If we're able to do that, we may have to pace you in the atria or the ventricle or AV sequential. The number one treatment of choice is magnesium sulfate. 2 grams diluted in 20 cc's D5W and given IV. Now, if you come from a family who has had prolongation of the QT levels, so you have a strong family history for congenital prolonged QT, you usually are going to need implantable cardioverter defibrillator therapy. So that's something we're not going to do immediately for you while you're in the hospital. We're going to control your TDP while you're there, and then we're going to send you, once you become more stable, we're going to try to send you down to the cath lab for the electrophysiologist to implant the ICD. Okay, almost done. Last is rhythm, almost the last is rhythm, ventricular fibrillation. As we all know, that's chaotic rhythm of the ventricles. It's lethal if it's not treated. And the causes of that are myocardial infarction, electrolyte imbalance, drug overdoses, trauma, heart failure, hyperstimulation of the parasympathetic nervous system, and an increased sympathetic nervous system stimulation. So it can be a side effect of all that epi and norepi that you're giving to patients. You want to always be aware of that. Now, what we're always going to do for VFib is defib. Always defib for VFib. And we do CPR, of course. We ultimately will consider in persons who have continuous episodes of ventricular fibrillation, we're always going to consider an AICD, right? When we defibrillate you, we're going to give you 360 if we're using a monophasic defibrillator. Most of us don't have that anymore. We have the biphasic defibrillator, so we start at 150 and move up in order to capture the heart. So remember, this is an electrical adenosine. It stops the heart, allowing time for the sinus node to take back over. And that's part of the reason we use this in conjunction with epinephrine. And epinephrine actually increases the ventricular foci's responsiveness, and it also stimulates the sinus node in the AV junction and can improve our outcome with those patients. Okay, so VFib, no R wave, right? No P wave, no R wave, just a rapid fibrillating rate of the ventricles. And it's extremely irregular and at a very rapid rate. No R wave, no P wave, no PR, just fibrillation. So very important for us to appreciate that visualization. So you're looking here at basically at a VTAC that then decompensates into VFib, and probably we would even call this a coarse VFib on the left-hand side to a fine VFib on the right-hand side. So what are we going to do? Okay, we're going to do CPR. We're going to do CPR till the defibrillator's there. We're going to check our patient and the monitor. We check 2 leads. We defibrillate. We continue CPR for 5 cycles, 2 minutes. We give epi first dose. We give epi second dose. We give epi third dose. And we also will consider vasopressin. And remember, that's going to be a rapid administration. We check our patient. We check the monitor. We do CPR. We shock. We do CPR. We give amiodarone. And now we might consider that we need to give magnesium, because we might have been in torsade and we didn't recognize it. So we're always going to consider magnesium. So this is very similar to what you're doing with ACLS protocols. It's a little expanded view because it takes into account that sometimes we miss the fact that you had an RNT phenomena and that you were in torsade du point. Okay, from there we move to pulseless electrical activity, and what you're seeing here is exactly what we looked at when we talked about heart block, right? The H's and the T's. H, hypoxia, hydrogen ion, hypo or hyperkalemia, hypoglycemia, hypothermia, hypovolemia, and the T's, toxins, tension pneumo, thrombus, coronary or pulmonary, trauma from increased ICP or from profound hypovolemia, and cardiac tamponade. Okay, pulseless electrical activity. You've got a rate, but you don't have a contraction. You have electrical, but you do not have mechanical. So the thing that's really important to remember is don't do anything to treat the rhythm, because that's not the problem. The problem is the filling of the ventricle and the ejection from the ventricle. What's obstructing it? What's caused you an issue that has lost mechanical contraction? So you can obstruct the outflow, that's like a pulmonary embolism or a tension pneumothorax or a thrombus formation that obstructs the outflow, or you just don't have enough volume to fill the ventricles, you're profoundly hypovolemic. Or your ventricular myocardium is hypoglycemic, or abnormal potassium at the cellular level, which then limits the ability for your ventricle to contract. So you have a failure of ventricular contraction. You have it from obstruction, but you also have it from direct alteration at the myocardial cells themselves. That happens most significantly when you have metabolic acidosis, hypoglycemia, and abnormal potassium as well as abnormal calcium. So we always want to think about potassium, magnesium, calcium, glucose, all those things if we're trying to save your life in PEA. PEA has the worst outcomes, but the thing so important about the PEA rhythm is that if we really recognize what the problem is and we fix the cause, that patient has a much better opportunity to survive. So I always want you to think about the H's and the T's when you're taking care of a patient who has PEA. Okay, so what are we going to do? Same thing that we did for VFib, basically. We're going to give CPR for 5 cycles, and we're going to interrupt it as soon as possible. We're not going to be defibrillating you because there's nothing to defibrillate. You are in PEA. We're going to give you epi or vasopressin, more epi, and then we're going to give you CPR. We might also give you atropine. That can help as well. But I want to make sure you are remembering the H's and the T's. So this is not, this concept of what we do with ACLS guidelines, this is not about actually activating the myocardium. Think about the myocardium. Think about your potassium. Think about magnesium. Think about calcium. Think about glucose. Consider that you need to replace those electrolytes, and you need to do that quickly if you want your patient to actually do better. And that's a really important concept for us to consider when we talk about PEA at the bedside. So the same thing with asystole, same exact issue. You're not going to defibrillate that. You're going to give epi, atropine, and CPR. And you're always going to consider that there's something mechanical that has affected activation. But one of the things I always like to say is in asystole, the very first thing you should be thinking about is pacing. You should always get your pacemaker, and that should happen quickly, right? So you're going to do CPR, you're going to give epi, you're going to give atropine if you give atropine. You're going to give CPR, again, you're going to give CPR. But you should be thinking about pacing this patient, because that's the only thing that's really going to save their life. So always reminding ourselves that that's the thing that we do. We look at PEA, and then we look at asystole, and we treat them exactly the same, okay? Because the problem is not going to be answered by defibrillation, because there is no fibrillation, because there is no activity. in asystole. Okay, so I remind you about the rate, fast or slow. Every P has a QRS. PR interval is constant. QRS is normal width. That P to P equals R to R. That gives us our answers. And we remind ourselves that there's an abundance of dysrhythm. I've done a very fast review of very common dysrhythms to see in the critically ill patient. This does not supplant taking an advanced dysrhythmia course or studying about dysrhythmias, learning everything you can, just reminding you that dysrhythmias interrupt the normal cycle of events and profoundly affect the myocardial contraction, which is what is bolusing blood out. And that is critically and profoundly important. We have to maximize ventricular contraction. So, management of dysrhythmias, pharmacologic, cardioversion, pacemaker therapy, surgical therapy, and interventional therapy. Ultimate goal is to control the dysrhythmia and restore rate. So I want you to remind yourself that we have a very significant class of agents. Class 1 are sodium channel antagonists, Class 2 beta receptor blocker, Class 3 potassium channel antagonist, Class 4 calcium channel blocker, and others that don't fit in any class. They're in their own class, adenosine and digitalis. So this is a list of antidysrhythmic agents and some of the examples of these agents and what it is they actually do. We're going to have a pharmacologic review at some point, and we'll be very close to the end of the class. We'll also have some in-person case studies where we're making some good decisions about giving drips to patients, how we use those drips, and what we're going to expect from those drips. But we just want to remind ourselves that many of our antiarrhythmic agents are actually pro-arrhythmic. And that's very concerning. That's one of the reasons we no longer use Class 1A or Class 1C agents without cardiology actually approving, because those are pro-arrhythmic dysfunctional agents. And we can see that also with our Class 3 agent, which is our potassium channel antagonist. Very, very important. Non-drug therapy, cardioversion, defibrillation, ablation, pacing, AICD. So the salient points. Always evaluate frequency of PVC and consider multimorphology. But never, never forget, you should always evaluate QTC. It tells us a prodrome of who's at risk. So I hope this helped you in the conclusion of cardiac rhythms. Now we get to move forward into hemodynamics. Fabulous. Thank you so very much. I look forward to seeing you soon. Bye-bye.